Okay, so Mr. PS is prescribed some celecoxib and he's referred for an ultrasound-guided peritendon steroid injection, and he returns 2 weeks later with improvement in symptoms, return to normal activities, but he's still got some swelling of the right knee, but not a huge amount of pain. And this is another feature actually of psoriatic arthritis. Not always, but not uncommonly, people have inflamed joints without a great deal of pain. And there has been at least one study that shows that people with psoriatic arthritis tend to report less pain than people with rheumatoid arthritis, which is curious. So what do we do now? What's the longer term management for someone with psoriatic arthritis who's kind of responding to your initial general treatment with non-steroidals and a local injection? So why?
Because it helps the skin as well as the arthritis. If the sort of a good effect.
Yep, that's true.
And people, I usually do well on it. Sometimes do well.
Sometimes it's very effective. Yep. Okay. Any other suggestions?
You want to avoid long-term damage to the joints from inflammation, current inflammation.
Yes, so you don't want people ending up with mutilans or deformities. Yep. And so that's another reason for using methotrexate or other drugs. Okay. Any other possible options? Okay, so this is actually quite difficult. And it's not as clear-cut as for rheumatoid arthritis, where the risk of joint damage is much more clear-cut. So we have to make a few considerations here. We have to think about the risks of treatment. So we know about the risks of long-term non-steroidal anti-inflammatories, cardiovascular disease, renal problems, GI problems. The risks of long-term conventional synthetic DMARDs like methotrexate, and the risks of biological DMARDs, which are particularly infections. So we have to weigh up the risks of treatment against the risks of having the disease. Now, in rheumatoid arthritis, the risks of having disease are quite substantial, so it's easier to make that kind of risk-benefit analysis. Psoriatic arthritis is a bit more tricky. So one of the things is that one size does not fit all. So when you look at the different sorts of ways that psoriatic arthritis can affect someone, not each manifestation responds in the same way to the different drugs. So, for example, the enthesitis part of the condition doesn't really respond very well to conventional synthetic DMARDs like methotrexate. Sometimes, but as a general rule, it doesn't. And certainly the back disease of psoriatic arthritis, or ankylosing spondylitis for that matter, doesn't respond very well to conventional synthetic DMARDs like sulfasalazine or methotrexate or leflunomide. On the other hand, synovitis manifestations do respond quite well to methotrexate in the same way that they do in rheumatoid arthritis. But one of the difficulties in knowing what to do is that most of the clinical trials that have been done for psoriatic arthritis focus on this group of people who have lots of swollen tender joints, because it's easier to see a response in someone with a large number of tender and swollen joints. There's more room for improvement, particularly when improvement is measured in the number by the number of swollen tender joints, and that's one of the key outcome measures in most arthritis trials, is how many tender and swollen joints there are. So it's very tricky to interpret the literature when we're thinking about someone with just one or two joints. Okay, so that's the first thing to think about. And then we have one of the other things we need to think about then is what is the risk of irreversible joint damage in psoriatic arthritis? And when we look at that, this is a study from Scandinavia, Sweden, which took an observational cohort of people with pretty early onset psoriatic arthritis and looked at their x-rays. So these scores along the bottom are different ways of assessing the damage to joints. And at the baseline, about half of them had 0 x-ray scores, in other words, no damage whatsoever. But after 5 years, that dropped to about 14%. So most people do eventually end up with joint damage from psoriatic arthritis. But when you see the magnitude of the joint damage, so these are the maximum scores you can get for each of those scoring systems, and those are the actual numbers. So you can see that they're actually pretty small amounts of joint damage. Yes, there is joint damage, but the magnitude of that damage is relatively low. And it's not clear what a very low score on a damage index translates into visible deformity or functional impact. So I think that even although we can say that most people with psoriatic arthritis do end up with some joint damage, whether that's important or not is still somewhat debatable. In this study, there were some predictors of more faster X-ray progression, so dactylitis and high disease activity. So people with dactylitis, and this has been shown in other studies as well actually, people with dactylitis tend to have more severe disease. And so that might, if somebody presenting early with dactylitis, that might be a kind of, might push you a little bit more towards being assertive with the treatment. Okay, so just go back. And the last thing to think about is the risk of cardiovascular comorbidity. So I'm not sure whether Andrew mentioned this in his talk on rheumatoid arthritis, but inflammatory arthritis is associated with a high risk of cardiovascular disease, and treatment of the systemic inflammation has been shown, at least in rheumatoid arthritis, to reduce the risk of cardiovascular comorbidity. Now, similar things can be said about psoriatic arthritis, but again, it's not completely clear-cut. So there's there is an increased risk of cardiovascular comorbidity in people with psoriasis and psoriatic arthritis, but it's not so clear whether that's because those people have higher rates of conventional cardiovascular risk factors like obesity and hypercholesterolemia and hypertension and so forth. And it's not been clearly shown that reducing inflammatory burden in these people will reduce the risks of cardiovascular mortality, but it's definitely something to think about. Okay, so basically what I've tried to lay out is the background for saying the decision making in someone with relatively mild disease is far from clear cut, and this is where what the patient wants becomes as important or possibly more important, because there is so much uncertainty here. So for people with very mild disease who are not functionally impacted and whose condition can be managed symptomatically with non-steroidal anti-inflammatories now and again, that's not necessarily a bad option. for someone with poor prognosis and whose disease has not been managed adequately with non-steroidals, then that's a different kind of question. But for Mr. PS, I think after talking to him, we decided that we would just manage with intermittent celecoxib. But that didn't go so well forever. And this is the other kind of message, I guess, is that just because you've decided on one treatment strategy at one time point doesn't necessarily mean that that's going to be the right treatment strategy forever. So periodic review is definitely relevant. So after a couple of years, he comes back with pain and swelling now of both knees and painful swelling of 2 toes. And he would like to explore other options because he's worried that celecoxib is becoming less and less effective. So, what do we do now? And I guess you've told me about at least one of them. So methotrexate was one option. Any other drugs that can be effective for psoriatic arthritis? Slazopirin, yep. Sometimes, not so much in psoriatic arthritis, but it's not unheard of. Yeah, that's an older drug that's been used for this indication. Yep.
Is it neostimin or something?
Cyclosporin or neoticacin. I think that's a retinoid used for treating skin disease, not effective for arthritis.
Would you do some baseline X-rays here to see if he'd developed any erosions or changes in his joints?
Yeah, and I think actually the time to do that would have been earlier, because that might help sway you towards a more assertive, aggressive approach rather than a kind of a wait and see. Yeah, so someone with baseline erosions is more likely to develop more erosions. So that's a very strong predictor of progressive radiographic progression is whether they've already got X-ray damage. So back 2 years ago, when you were thinking, well, what should we do? Some X-rays then might not have been a bad idea. I agree. But here we're thinking, well, we're going to do something anyway. So having that information might help with interpreting subsequent imaging, but it's not going to help so much with the decision making. Okay, so so again, we have to consider the fact that methotrexate and sulfasalazine and those drugs don't really help the enthesitis very much. But at this point, he's not really complaining so much of that. So it's the knee swelling, pain, dactylitis, which could potentially respond to conventional synthetic DMARDs. And there's quite a lot of drugs to choose from. And this also poses problems with knowing what to do. So in New Zealand, we've got 3 main conventional synthetic DMARDs that Andrew probably talked about a lot with this rheumatoid arthritis. So methotrexate, sulfasalazine, leflunomide, and then azathioprine, in sort of a smaller print, azathioprine, cyclosporin, and apremilast. Now, apremilast is effective, but it's not subsidised. Azathioprine and cyclosporin are subsidised, but they're quite toxic and probably less used less often these days in comparison to these 3 drugs. And then there's a list. Then there's a bunch of biological DMARDs. So there are 3 anti-TNF agents in New Zealand. These 2 are given by subcutaneous injection. This one's given by intravenous infusion. And then there are 2 biologics that are new and work on a different cytokine system altogether. So secukinumab is a IL-17 blocker, and ustekinumab is a IL-12/23 blocker. Now, secukinumab is actually funded for people with psoriasis. They've got to have really bad psoriasis, and I think they've got to have tried an anti-TNF drug, but I'm not absolutely certain about that. But it's only funded for psoriasis. It's not funded for psoriatic arthritis at the moment. Ustekinumab has, although it's been shown to be very effective in psoriatic arthritis, similarly, ustekinumab is effective for psoriasis and psoriatic arthritis, but it's not funded.
Are they on the verge of becoming funded?
I don't think ustekinumab is likely because it's been around for a while and there's no progress, but who knows? I can't answer for PHARMAC, unfortunately. Okay, so the choice of drug, again, rationally should come back to thinking about the potential benefits and the potential risks. But in practice, it comes down to what's available and what you're used to prescribing, unfortunately. And so methotrexate and sulfasalazine tend to be the most commonly prescribed first-line DMARD drugs for psoriatic arthritis in practice, particularly methotrexate because it's quite, as was pointed out before, it's quite an effective drug for skin disease. So if somebody's got skin disease as well, then it's quite sensible. Now, having said that, methotrexate's the most commonly used drug. It's actually the drug with the least amount of evidence for its effectiveness. And in fact, there has been only one clinical trial testing the hypothesis that methotrexate is an effective drug for psoriatic arthritis, and it didn't show that. Yet, nobody really believes that trial. So it's a confusing area. Sulfasalazine has been shown in clinical trials to be moderately effective, but doesn't really help the skin very much. Leflunomide's definitely been shown in a couple of large studies, more than two probably, to be effective for the arthritis and to a lesser extent the skin disease, much lesser extent the skin disease. Whereas the biological DMARDs have all been shown to be very effective, yet they're very expensive and they're associated with increased risk of infection, so they tend to be very much second line. So I'm not going to go over each of those drugs in detail, but you asked a question before about what's the minimum monitoring necessary for these drugs, and they do tend to be very similar, although there are a couple of idiosyncratic issues. So, for example, with methotrexate, you might want to measure the creatinine every so often because impaired renal function can increase the toxicity of methotrexate. And with leflunomide, hypertension can be a problem, so it's prudent to monitor people's blood pressure periodically with leflunomide. So the first thing I just wanted to emphasise, you probably know this, DMARDs work very slowly. So you can't make a judgment about whether it's effective or not, but much before 6 to 8 weeks. And sometimes that can be prolonged even further because you're changing doses. So you may start with a smallish dose, and then if they're no better in 6 weeks, increase the dose. So you have to wait another 6 weeks. So it can take a while for people to cycle through these drugs, unfortunately. Yeah.
How long does the efficacy linger? Because sometimes people say, I'm going to stop taking this in a week later. I feel fine, so I didn't need to take it.
Yeah.
Is it because this drug is still...
Yeah, that definitely can happen, yeah. I can't tell you exactly. I think there's quite a lot of variation again, but several weeks is not uncommon, yeah. Okay. The other thing about drugs that have some effect on the immune system is what to do about vaccinations. Live attenuated viral vaccinations like the zoster vaccine should probably be avoided in people with taking methotrexate. Or at least not methotrexate so much, but the biological DMARDs or high doses of prednisone. Because the infection risk is mainly seen with the biologics, not so much with the conventional synthetic DMARDs. And that means thinking about using antibiotics a bit earlier in those people on biologics than you might otherwise have done. And biologics should be discontinued prior to elective surgery, but not really. It doesn't really apply to the oral drugs like methotrexate, leflunomide, and sulfasalazine have a very low increased rate of infection, and we don't generally recommend stopping those before surgery. And I mentioned some of the particular adverse event profiles with particular drugs. Okay. So when do I carry on to? Yes, 5 minutes. So there's a couple of even newer drugs coming to our place hopefully soon, and they all have completely unpronounceable names. So you might have thought adalimumab was bad, but this one is a real confounder. I think it's called ixekizumab, but I might be wrong. But this is another IL-17, and it turns out that IL-17 is a really important pathway in psoriasis. This is a study of psoriatic arthritis, but in studies of people with psoriasis, this drug works completely, like it completely clears very severe skin disease, even in people who don't respond to anti-TNF drugs. And this is a study of people of psoriatic arthritis who didn't respond to TNF drugs, this is the two dosing regimes of the ixekizumab compared to placebo, and you can see that there's quite a difference in their outcome.
My understanding is that the more unpronounceable the name, the greater the placebo response.
That's possibly true. Yeah. Okay. And this is another one called guselkumab, which is an IL-23 inhibitor, and again, this is an interesting study because it's not a placebo-controlled trial; it's an active comparator study where in the red is adalimumab, which is one of the most commonly used anti-TNF drugs, particularly in New Zealand, and 2 doses of guselkumab works better than adalimumab in this kind of head-to-head study. So there are more drugs coming around the corner that look even better, but I'm sure they'll be very expensive. So coming back to Mr. PS, we do start him on methotrexate. His symptoms improve after several weeks. He did have some initial nausea. So nausea is, as you saw in Andrew's patient, are pretty much the commonest side effect of methotrexate. In many people, it does seem to settle down. So I generally tell my patients, just carry on for a few weeks, and if you're not throwing up and it's not too bad, just persist for a bit. But if it's awful, then just stop. And he has a general checkup, and his blood pressure is found to be a bit high, 150 on 90. Now he's a non-smoker. He's got a normal HbA1c. There's no family history of early cardiovascular disease. His total cholesterol to HDL-C ratio is 5. So looking at the traditional risk factor algorithm charts, you estimate his 5-year cardiovascular risk is no more than 5%. Okay, so the question is, how should cardiovascular risk factors be managed in people with psoriatic arthritis? Remember, this guy's under 40.
Is he Maori or Pacific?
No, he's Caucasian. But that's a good point.
You say that the cardiovascular risk assessment's elevated anyway, the estimated risk because of
Yes,
information. So that 5% is not taken into account?
that's correct. So the charts that you use, or the algorithms, I don't know whether, is it the predict tool that's now in place? I don't believe that takes into account inflammatory arthritis. I think it takes into account other factors, but not that one.
So what would you elevate his estimated risk by, given that he's got psoriatic arthritis?
Yeah, well, that's an excellent question. And in rheumatoid arthritis, it's recommended that the risk be inflated by 1.5 times. I think that's right. In psoriatic arthritis, the risk inflation factor is a little unclear. So it's uncertain. Yeah, there's been at least one study that shows that having psoriatic arthritis itself didn't increase your risk over and above the conventional risk factors that you already had. Yeah.
So 1.5 times, does it mean 10% goes to 15?
So you multiply 5 by 1.5, so that goes to 7.5.
So would you start screening these people earlier?
Yeah, well, I think that's a prudent. I think that's a reasonable suggestion. You may not necessarily know what to do when you do find something like slightly high blood pressure, but I think the general recommendation is that people be monitored more closely for traditional cardiovascular risk factors. Yep.
Patients are right. I generally say you've got a higher risk factor, and that makes it more important for you to look after your own health, maintaining an exercise program, healthy diet.
Yeah. So definitely thinking about non-pharmacological methods of managing vascular risk factors. I think that's very sensible.
But I do think it's important that we tell these patients that they've got a higher risk, because sometimes when an adverse event happens to them, and they come back to you and they've said, well, nobody's ever told me that I've got a higher risk.
Yeah, I think that like lots of decision making in conditions of uncertainty, patients will have their own view about what should be done, and if they are of a mind that wants to minimise risk no matter what, they might be quite keen to take antihypertensive treatment, even though you don't necessarily think it's completely necessary. Yeah. So this is kind of already what I've said. Yeah. Main recommendation is to monitor and treat risk factors a bit more diligently. You just got a bit more of an awareness of the issue. That's the main message. So I think that's me.